Welcome to Expert Perspectives. We're here at the third day of Lymphoma and Myeloma, an international conference on hematologic malignancies being held here at the Waldorf Astoria in New York City. I'm Morton Coleman, Director of the Center for Lymphoma and Myeloma at Weill Cornell Medical College in the New York Presbyterian Hospital. I have with me my close colleague, Dr. John Leonard, who is the head of the Lymphoma Committee of the Alliance, which was formerly CALGB. Dr. Leonard heads up many prestigious committees and has been involved in lymphoma research for many years now. John, welcome to Expert Perspectives.
Thanks, Mort. I appreciate the chance to be here. And first, I want to congratulate you with such a great meeting. For those in the audience who haven't been here, this really has turned into really one of the best meetings, I think, on lymphoma and myeloma in the world. And the meeting just grows. The speakers love to come here. It's really a great venue to be able to talk about the latest findings. So it's nice to be here tonight.
Well, I certainly couldn't accomplish any of this without your good help and the help of my other colleagues at Cornell. We'd like to discuss with you some of the interesting new aspects which were discussed at the Lymphoma and Myeloma Conference. And one of the interesting questions which has come up is, what is the exact role for these new signaling inhibitors with both low-grade and perhaps even high-grade lymphomas? Where do you see their place in their armamentarium for the treatment of lymphoma?
Well, I think that's a big question, but an important question. And as people who are clinically in practice taking care of lymphoma patients and CLL patients, we now know that we have a couple of tools available that fall into the class of signaling inhibitors. One of those would be the BTK or Bruton's tyrosine kinase inhibitor, and that's ibrutinib. That is FDA approved for patients, certain patients with CLL and mantle cell lymphoma, certainly being studied in a variety of other clinical situations as well. It's also, there are additional BTK inhibitors that are in clinical trials, so it's likely that much as we've seen with the drugs that target the Philadelphia chromosome, that down the line we'll probably see additional inhibitors of BTK in practice. So we'll start first with BTK and then move to a different category. So idelalisib is a drug that I think, as this audience likely knows, B-cell malignancies, part of the viability of cells, the proliferation of cells, and the general happiness of cells relates to signaling through the B-cell receptor and downstream pathways, keeping those cells alive and happy. And so inhibitors of BTK have been shown now to basically interfere with proliferation of cells, particularly, again, cells of the CLL phenotype and cells in mantle cell. And so I think if we go disease by disease, because I think these agents will touch, or this agent particularly, will touch a variety of settings. Certainly the ibrutinib, the BTK inhibitor, is FDA approved in patients with primarily recurrent CLL, where there's high response rates, high clinical activity, and pretty good tolerability profile. And so I think what we'll be seeing is more and more exploration of the use of BTK inhibitors, either alone as upfront therapy or in combinations. But really in clinical use today, I think they're primarily being used with patients with relapse disease and very exciting results.
Yes, tell me, if you had to make a choice between ibrutinib and idelalisib, it's always a hard question since they've never been and probably will never be compared head to head. Do you use the comorbidities of the patient in terms of selecting which one you're going to use? They've both been approved for previously treated chronic lymphatic leukemia.
Right.
And the second question is, the response rates in lymphoma have been rather good, but not quite as good as those responses with CLL. Do you have any opinion on why that's so?
Right. So you allude to the other category of kinase inhibitors, idelalisib, which is a PI3 kinase inhibitor. PI3 kinase is an additional kinase that's more or less connected to BTK in the pathway. And so some of the effects that we see with idelalisib, the PI3K inhibitor, are similar to what we see with ibrutinib, but some are different. The pattern of sensitivity in CLL is similar, meaning that they're both very active drugs in CLL. The pattern of activity in lymphomas is a little bit different. Mantle cell lymphoma, ibrutinib is approved and active. Idelalisib is also active, but with shorter, I think, progression-free survival. Both seem to be active in follicular lymphoma. Idelalisib is approved in follicular lymphoma, in refractory follicular lymphoma. And I think both have been relatively underexplored in aggressive lymphomas like large cell lymphoma, although we do have evidence that ibrutinib seems to be active in the activated B cell subtype of large cell lymphoma. So to specifically get at your question relating to CLL, they're both active in CLL. They've been studied in different ways. Ibrutinib as a single agent predominantly, at least in the approval studies. Idelalisib in combination with rituximab, and certainly our colleague Rick Furman and you, of course, have been involved in several of these studies. I think that the efficacy in some ways is quite similar. They haven't been compared head to head. So I think the big question is going to be, if you have a patient that gets one of these drugs, are they going to be sensitive to the other drug if they become resistant, or are they cross-resistant? That's the million or billion-dollar question, and we don't know the answer to that. I think at some level, some of this will relate to the toxicity profile. I think in some ways we have been seeing a little bit more toxicity with idelalisib with respect to monitoring liver enzymes and occasional patients with colitis and inflammation, and that probably is related to kind of secondary T cell and other immune effects that idelalisib seems to have a little bit more. But at the end of the day, they're not the same drug. I think for some patients they'll be very similar, and in other situations so it'll be this Venn diagram, I think, where they have similar activities for certain patients but different activities for others. And we're just getting into teasing that out. And ultimately, I think one question that we've talked about is, should we use them in combination? And I think ultimately we're going to be looking at those. The issue there, I think, will be, you have drugs that are relatively well tolerated. When you start to combine them, are you going to see additional effects that, yes, they're pills, but are we going to see additive or worsened toxicities? And so all of these, as you know, we're working on very extensively to try to sort through.
Yes, I think some of us are now looking at comorbid conditions to make a decision on which drug to use. For instance, if a patient is on Coumadin and requires Coumadin, that perhaps maybe idelalisib would be the preferred drug, whereas if the patient has a history of ulcerative colitis, you might opt to go for ibrutinib. But you're quite right. I think that we've just begun to just touch the surface of the potential of these drugs. One of the other issues that came up at the conference was, how do you handle double hit or triple hit lymphomas, which have been really the bane of our existence? Perhaps you might tell us what a double hit or triple hit lymphoma consists of, and how do you approach it? It's a difficult question indeed.
Yeah, it's an excellent question, and as you alluded to, was one of the topics at our meeting, and it seems like every year that becomes a topic at our meeting, because we don't know what to do, and the world is changing, and people in practice need to know about this, because we struggle with this. And that's, I think, one of the examples of this meeting where the topics are really things that people in practice need to know about. And so the definitions of a double hit or a triple hit lymphoma, I think, are in flux, and there are a couple of different, the issues or the genes that we're dealing with relate primarily to BCL2, BCL6, and MYC. And so it is, the hits relate to abnormalities or overexpression of those either genes or pathways that are associated with subsets of patients with large cell lymphoma. As the name, as you allude to and know well, the double hit really is having abnormalities of 2 of those, and the triple hit would be having abnormalities of 3. So people are used to seeing BCL2 positivity or BCL6 positivity, but having these combinations is really how one defines the double and triple hit. And these sorts of things happen probably in the range of 10 to 20% of patients with large cell lymphoma, again, depending on the definition, which we'll come to in a second. And so, if you're in practice, you see lots of large cell patients, every once in a while there will be double hit in nature, and you need to think about this and talk to your pathologist about this if they haven't done the requisite analyses. So double hit can be defined by FISH or by protein expression, and the literature is replete with studies that have looked at FISH positivity or FISH abnormalities looking at the gene, or protein overexpression, which you can see in patients even without the genetic abnormalities. And so when one looks at the literature, one has to look at the definitions. I think that one of the larger series most recently has suggested that basically both are bad. If you've got the gene, that's better than not having the genetic abnormality. If you've got the protein, that's, the genetic abnormality, having it versus not having it is bad or unfavorable. And then the protein, having these protein overexpressions versus not having, is also unfavorable. So protein matters, gene matters. Is it both? Is it one or the other? Is one worse? I think the bottom line is that that's a moving target. Probably the gene is worse than the protein if you only have one, but the protein expressing, again, BCL6 or BCL2 or MYC or those combinations is probably less favorable than not altogether. But it's a moving target, and I would say, as you know, the literature, it really defines this differently. And one of the topics that was discussed, one of the studies that was discussed at the meeting, relates to a recent publication in Blood and some data by really a multi-center group that looked at this and collected several hundred cases of double-hit lymphoma. In that study, they looked at the subset of patients, they used the definition of genetic, of FISH double hit as opposed to protein. And this was several hundred patients, retrospective analysis. And I think the key conclusions are that you have to get the patient into a complete remission, and that the different approaches to look at this retrospectively included hyper-CVAD, included EPOCH, included CHOP or R-CHOP or rituximab combinations with all of those. These are B-cell lymphomas. And the net of that study suggested that there weren't huge differences between those three regimens. I think most people, if the patient is younger, would use a more Burkitt's type regimen. If the patient's older, I think most people would use something like EPOCH or something along those lines, although we don't have randomized comparisons. And then the question of, okay, you get the patient in remission, do they benefit from a transplant? And these were retrospective analyses with all the inherent biases. There were some suggestions of a benefit of a transplant, but really this, despite being several hundred cases, doesn't give us a definitive answer of what to do. I think the net is that if you go into CR, you can do well, and it's not clear that the transplant helps there. If you don't go into a CR or you progress quickly, you're going to do poorly, and it's not clear that a transplant really helps you there either. And so I think the key thing is that some of these patients do well despite having these abnormalities, but it's a minority. And the key thing is, what do we do about these patients that are destined to do poorly? They tend to progress earlier or not go into CR, and that's really where the clinical challenge is.
If I remember correctly, there are very few who actually enter CR. So
that's right. It's a minority.
It's a very difficult situation to be in. Would you kind of tell us what should a clinician look for to suspect double hit? Talking about Ki-67 and all the other clinical factors that you often see that you measure with the IPI.
Right. So as I've learned from you over the years, one of the challenges is that you have an adverse prognostic factor that goes along with an adverse IPI, and so it's which came first, the chicken or the egg. So double hit lymphoma patients tend to have multiple IPI risk factors, and they also tend to have a little more CNS involvement, tend to be a little more in older patients, high LDH, et cetera. And so, which is it? Is it the double hit giving rise to the bad features being associated? But I think if you're seeing a patient with multiple IPI risk factors, high LDH, lots of extranodal disease, perhaps older patients, though not always, and in particular, if you're seeing high Ki-67, a highly proliferative tumor, that should alert you that you should be talking with your pathologist and thinking about this. Interestingly, one of the other things that came out of this paper was that the stage in this matters, and those with advanced stage, not surprisingly, tend to do less well, but the subset that seemed to do better, and I would say in my own practice, I'm interested if you've seen that, I've had a few patients that have fallen into this group that really have had limited stage disease, and again, lower IPI risk factors. That seems to me to be the group that goes into CR more commonly. And the question is really, if they go into CR, do you really need to do the aggressive sort of treatment?
Unfortunately, there aren't very many that have limited stage disease.
Exactly.
Now, one of the other issues that came up in the conference is how do you approach ABC versus non-germinal cell lymphomas versus germinal cell lymphomas, or what we refer to usually as ABC.
Right. So great question, and as the audience likely knows, because there have been many publications by various groups suggesting that the ABC subtype, also known as the non-germinal center, depending on how you're defining the subgroup, is really a group of patients where they tend to have a less favorable prognosis, and they're associated with a number of different activation of a number of different pathways. And so now we have some targeted drugs that get into those sorts of mechanisms and tweaking them. So I think there are a couple of ways that in that adverse prognostic group one could think about targeting this subset specifically. So one is work that we did, and you were a big part of the idea that NF-kappa B activation is associated with the activated B cell subset. We together published some data in our group and others looking at bortezomib in that group of patients and suggesting that addition of bortezomib to CHOP may help the ABC subtype. And as you know, there are randomized trials, several randomized trials going on based on our work looking at this across the world. So bortezomib is one strategy. We'll see the results of that. The second strategy where there are data include using lenalidomide. And lenalidomide as a single agent seems to be more active in relapsed large cell lymphoma in the non-germinal center subset. And we have several studies, some out of Mayo Clinic and ECOG, some from the Italian group, suggesting that adding lenalidomide to R-CHOP may improve the outcomes there. And there are randomized trials looking at that question specifically. And then the third pathway that we have, or the third agent that we have now, is, as we alluded to earlier, ibrutinib. And ibrutinib seems to have some single agent activity in relapsed large cell lymphoma, more restricted or more concentrated in also this ABC subtype. And so there are data showing you can add those drugs safely to R-CHOP, and there are randomized trials looking at that subset of patients. I think the challenge is that that's not, large cell lymphoma is common, but you really end up talking about, more or less 30 or 40% of patients. And trying to do a randomized trial in a subset of large cell lymphoma is something that is still a work in progress. And it'll be interesting how these accrue. They have accrued to some degree in various settings, and we'll see what those data show.
I believe IMiDs have also been used,
right.
particularly
lenalidomide, exactly.
lenalidomide.
Yes.
But what do you tell the practitioner out there? Do you still stick with CHOP Rituxan, or would you have him add one of these other drugs?
It's a great question, and when you pose it that way, it's a tough one. I think it's at this point outside of a study, I would stick with kind of standard R-CHOP. It's pretty clear that there's more toxicity when you add these drugs. I think that it's manageable, and obviously if you cure 10% more patients or whatever it turns out to be, if in fact there is a difference, it may very well be valid. But I think at this point, there have been lots of examples of phase 2 studies that have suggested benefit in large cell, and when we get the randomized trial, we haven't seen it. So I think in practice, I would stick with the R-CHOP at this point.
What about EPOCH-R? Certainly, your committee has been very much interested in the randomized study between CHOP Rituxan and EPOCH Rituxan or rituximab.
Right.
Are you at the point now where you would consider using EPOCH-R in place of CHOP-R in a young patient, or would you still stick with the CHOP-R?
Well, I think that those data, as you know, that study's in follow-up right now. We've accrued it. We're having molecular profiling, and so we'll be able to correlate the molecular subset with outcome both with our CHOP and with our EPOCH. I think that the earlier studies suggested that our EPOCH, the benefits, at least by retrospective comparison, seem to be more in the germinal center subtype. So it's quite possible the future may be germinal center gets EPOCH or our EPOCH, and non-germinal center gets our CHOP with ibrutinib, lenalidomide, bortezomib, or more than one, or pick your flavor of those. I think that probably those sorts of slicing and dicing the groups of patients may be where we end up. But today I've not been using our EPOCH outside of studies. The exceptions might be patients that have a more aggressive type. As you know, there are some data with the more Burkitt type lymphomas that our EPOC could be acceptable there. So for instance, in an older patients where I was looking more at a Burkitt type situation, I might use our EPOC rather than giving them hyper-CVAD or something more aggressive. And then the other setting where we have some data, albeit non-randomized data, is single-arm data looking at the primary mediastinal lymphoma with our EPOC. And I think the main advantage or potential advantage there, particularly as you know in young women, is trying to avoid radiotherapy. And at least the data that we have to minimize breast cancer risk and long-term toxicity suggests that you can get high effectiveness and avoid radiation and the potential risks of that using our EPOC. Now again, we don't have randomized data, but I think that that's a scenario where I would consider that approach.
There may be some additional merit in the fact that you're infusing the adriamycin and not getting the peak levels in terms of cardiac toxicity, at least for an elderly patient.
Mm-hmm.
And one of the other major controversial issues has been how to approach a patient with mantle cell disease. Should a patient who is eligible for transplantation receive a transplant? Do you think there's a role for doing a transplant after you've treated the patient with your first regimen and have achieved a complete remission? Where would you go with this? Would you transplant everyone, or would you transplant no one, or would you be selective?
Mort, how long is this program scheduled to be? I think that if we have another hour, I think we can cover that. And as you know, that we've had debates at this meeting and discussions at this meeting on that topic. I think the pendulum is swinging. I think that certainly in younger patients with mantle cell lymphoma, the story had been if you could tolerate an intensive treatment, if you can tolerate a transplant, that you should get it. It's clear that intensive regimens provide a progression-free survival benefit, but it's not clear that there's an overall survival benefit. So I think the past has really been, look, you can get a transplant, you get it, you may not live longer, you'll be in remission longer. Some people would argue you live longer, but I would say that those data are not at all definitive. And obviously with the new agents we have and the new approaches we have and new data, we certainly have additional treatments that can rescue or provide good therapeutic effect for patients in the relapse setting as well. And so and as you know, we have been really focused on less intensive treatments with the understanding that patients may not have as long of a remission, but there's not necessarily any decrement in survival. And the fact is that if chemotherapy doesn't cure you in this disease, which it doesn't seem to do, then really you have lots of different choices. And the choice of a period of intensive treatment and the toxicity associated with that, with a long remission versus being on a lower dose kind of chronic therapy that may have chronic toxicities but less acute toxicities, that's a choice that we're making. That's a choice that's coming up in myeloma as well. I think some of that is the same story in myeloma. And I think with the novel agents we have, we really need to reevaluate that. And honestly, I think the biggest challenge that we have is assessment of quality of life. You talk to a patient, and that's what we do in practice. We talk and we work with them to sort through, are they someone who's going to be better psychologically and quality of life going through an intensive process, or are they the person who would rather avoid that and perhaps not be as bothered by a little bit of nagging toxicity by being on some chronic oral therapy for a period of time. So I think we're moving, but we need those randomized trials to get a better
And finally, what do you see in terms of the role of cytosine arabnoside in mantle cell treatment and also Rituxan maintenance or rituximab maintenance? Do you see a role for both of them in the treatment of mantle cell lymphoma?
Well, I think the European Mantle Cell Consortium group has showed that outcomes seem to be better if you're getting a transplant and getting chemotherapy if you have cytosine arabnoside as part of the treatment regimen. So I think if you're going the route of a more intensive treatment, chemotherapy-based, transplant-based, it seems to me to make sense to include Ara-C. Now on the flip side, if you're not going that route, do you need to go out of your way to toss in some Ara-C somewhere in the course of therapy? And I would say, as of now, I don't see evidence for that. and I don't routinely give that to patients if I'm using a less aggressive approach. And perhaps what you're alluding to with the second part of your question is we can get a lot of mileage with perhaps a less aggressive regimen, perhaps a bendamustine-based therapy. We now have data with CHOP plus bortezomib, again as a follow-up to what we had done, and randomized data showing good progression-free survival benefits. So the issue is, can we use a moderate dose chemotherapy, non-myeloablative outpatient regimen, and then with rituximab maintenance, maintain that remission for 4 or 5 years, something comparable to what one might get with a transplant. And then obviously, could we even do better than that with some of the novel agents like lenalidomide, ibrutinib, et cetera? And so, I think the idea of giving a lower dose chronic therapy, and probably in combination, is one that to me holds a great deal of appeal.
Well, the conference has certainly been very illuminating, and your commentary equally as illuminating. John, thank you very much for giving us some of your very valuable time. This is Dr. Morton Coleman signing off from Lymphoma and Myeloma 2014. I wish you a good day.